Alpi, good evening. You can start. Let the people keep on joining. It's already 8:10.
Okay, sir. Okay, sir. Good evening, everybody. I am Dr. Alapi Prajapati, and I am assistant professor at Department of Psychiatry at TCS Medical College in Ahmedabad. And I am going to moderate today's webinar session. I think today is also one another session, so people are joining in. So I would like to welcome you all. Good evening, my respected seniors, my dear colleagues, and postgraduate resident doctors. I like to specifically mention our honorary president of Indian Psychiatric Society West Zone, Dr. Shirod Mishra, sir. I welcome you, sir. On behalf of Indian Psychiatric Society West Zone Women's Mental Health Subcommittee, it gives me immense pleasure to welcome you all to today's webinar session on a deeply significant and often under discussed topic, and that is supporting the women in addiction affected families. Addiction does not affect just one individual, as we all know. It reverberates through families and specifically women as daughters, as mothers, wives, caregivers, silently carry that emotional, social, and financial burden of this substance use in the family. Their distress is often very silent, invisible in clinical practice, overshadowed by the substance use in the person. As psychiatrists, our role extends beyond just treating the substance use in the person. And of course, we are responsible to address some important problems like intimate partner violence, even codependence, problems of intergenerational impact the substance use leaves on such families. So today's discussion in this reference is very relevant for all of us. We are all honored to have the esteemed speaker of today's evening, Dr. Piyush Goel sir, who brings with us his clinical experience and academic expertise. He has done his MD psychiatry from BJMC Ahmedabad, and sir has done DM in addiction psychiatry from AIMS New Delhi. He has extensive work experience at different hospitals at Mumbai, Navsari, and currently he is working at Aura Clinic, which is situated in Surat. Sir is a life fellow member of Addiction Psychiatry Society of India. He is also a member of Indian Psychiatric Society, Gujarat Psychiatry Association, and also he has extensive experiences. I think his area of interest is opioid and opioid substitution therapy, also methadone management program. He has received training in harm reduction, needle exchange program by NARCO, and also experience in management of substance use along with pain, liver disease, and other comorbidities, which he did in AIMS. So I welcome you, sir. I request all the participants to actively engage in the discussion and question answer round at the end of the session. Also, you can put your questions in the chat box, which will be addressed at the end of the session. I welcome you, sir.
Thank you. Thank you, Dr. Alapi. Good evening, everyone. To all my seniors, my friends, my juniors. Today's topic is highly relevant if we talk about addiction, and especially in Indian settings. Dr. Alapi, is my slides visible?
Yes, sir. Yes, sir. It is visible.
So, okay. Before going to the main sections of the seminar, what I'll try to tell is that what I have done is that the main problem that the substance user faces with his family is that substance use is not stopping, and because of the ongoing substance use, the family dynamics changes, and the family members suffer in different domains of their life, whether it is psychological domain, either from depression, anxiety, whether it is uh, intimate partner violence, whether it is bringing patient to treatment. So all these kind of things change. But what actually happening is, if we look addiction as a family disease, uh, it tells us that if something happens in a family, for example, when the person was not using alcohol or substance, the family had a different homeostasis. But as the family member, suppose we will, in most of the slides we will take the example of alcohol, because it is not possible for me to cover all kinds of substance. There are minor differences in family dynamics with different substances, but most of it is same. So if we take the example of husband and wife, so husband had started alcohol use. From now on, the family also changes, the interaction between family member changes, and that is responsible for the continued use of substance. So we will try to identify the different pathological patterns that goes in the family that is responsible for uh, perpetuating and continuation of substance use in the male member. So I'll start with three case scenarios, and all three case scenarios are different one. And on basis of these cases, we will discuss further what is actually happening. So this is case one. Please pay attention to these cases. So Mrs. X, whose husband is addicted to alcohol, and his behavior gradually had become very erratic. Now she has taken the role of a caretaker, and she manages the finances of the house, because the husband is not able to work properly and he's not able to function properly at work. Also, she has started covering up her husband's absences at work, and because of his absence at work, she is lying to the extended family members that uh, the husband's substance use. She's trying to cover up the substance use of the husband to maintain a facade of normalcy. Gradually, as the substance use increases, what happens is, due to fear of domestic violence, she even provides money for his substance use. She has warned him that she will leave multiple times, and she has also told him that if this continues this way, that she will dissolve the marriage. But due to societal pressures and parental fears, she continues the marriage. Many a time she had ran to her parents' home, but she comes back becoming worried about children being raised without father. And also, her parents are not ready to keep her in their home, telling that, okay, everything will all right, they will talk to the husband. But she should not live apart from the husband. Many a times, under intoxication, when he comes home, he falls on the floor in the house, and she, along with the children, have to put him on the bed. One evening, while he was drunk, he insisted her to go to watch her a movie with him. Mrs. X, out of fear that if she doesn't go, he will start fighting, and also thinking that this can be a chance to improve relationship, went for a movie. During driving back home, he was stopped by police for drunk driving. Mrs. X pleaded police to leave him this time, begging that if he catches him, the name will go bad and he will lose his job. Because of all this happening in the family, she suffers from anxiety, sadness, lots of anger, and a strong sense of guilt. She keeps telling her husband to stop, and he is not listening. She has come to know about the medications, which, when given covertly, can make him vomit after drinking alcohol. There are others in neighborhood who have also told her that she should put him in a rehab for a period of 5 to 6 months by arranging a so-called pickup. So this is one case. We will discuss it after the case 2 and case 3. Okay. Now this is case 2. Mr. Y has been into treatment for alcohol addiction. He was quite motivated for his treatment, and he had good insights about his alcohol use, how it has been causing him and his family problem. And he had come to treatment by self along with his wife. He has been provided with some medications, and he visits the psychiatrist in 15-20 days with his wife. In last 2 months, his alcohol consumption has also decreased, and but still he is not able to completely stop his alcohol use, and he drinks in every 3 to 4 days. When the doctor inquired about the last 2 month result, that uh, his consumption has decreased, wife told that she is still not very happy with him, because even any kind of drinking is drinking, and she still thinks that he is not making any efforts. She still feels that until it is not stopped completely, there is no uh, way of no point in stopping that heavy amount also. When doctor asked what help he can provide to further reduce drinking, uh, she replied that she has done her part and she cannot do anything more. And she told that it is because of his choice that he is drinking, and he does not care for his wife or his children. Further inquiry revealed that husband is not allowed to go out alone to work, and he is accompanied to work by his father-in-law, and someone also accompanies back him home. When husband has been probed that what is leading to his drinking for 2 to 3 days in a week and why he is not able to stop completely, he expresses that he feels guilt and shame for the same, that every day he has to go to his work with his father, and he has to come back also home along with someone, and he's not left alone even for 10 or 15 minutes. He had tried to communicate this to wife that he is trying his best, but she tells he cannot take risks and he has no trust in him. Whenever he is alone and no one is around, what happens is he feels a strong urge to drink, and he drinks very fast while he is in his car due to fear of getting caught by police, because drinking is banned in Gujarat. When he comes home, he tries to hide his alcohol use because he fears his wife that she will end up with a heated argument and she will start criticizing him. Again, the next day after everything is over, he again feels guilty and he feels no one is praising his efforts and understanding him. And this guilt again makes him drink in the evening. And this pattern is going on. Now, this is case 3. Mr. A is alcohol dependent for 10 years. He is a rich, successful businessman and is very regular to work. He is earning well. He has never felt alcohol use is a problem. Wife has been worried regarding his future consequences on physical health due to occasional blackouts and deteriorating health. Wife is continuously nagging him to go to visit a psychiatrist, and he told that he will not go, but he will take medications if any she brings from the psychiatrist. Psychiatrist prescribed him anti-craving medications and some benzos, which he takes irregularly whenever he feels. When wife asks about any change in his drinking with meds, he doesn't reply properly and he doesn't tell anything that what is happening with him. He tells her he will come to the doctor with her, but since 6 months, every day he has been prompted to visit doctor, but he has not visited the doctor. Wife has gradually fed up, and because of the facing stress and sleep issues and lots of alcohol that is kept at home, she had also started drinking occasional for relieving stress. So now, before going further, I would like to have a discussion on case 1, case 2, and case 3. So, can anyone tell that what is happening in case 1 and how all these 3 cases are different? Because these are the very common patterns that we see across in OPDs. There are multiple other patterns, but I think these are the most common patterns. So, I would like some feedback on these cases. Dr. Alapi, can you tell everyone to give some feedback?
Yes, so sir is asking that what is your take on these cases? What is happening actually, particularly with women in the family?
Because on basis of these 3 cases, the rest of seminar I have made. So has anyone identified that what case 1 is telling? What is happening in case 1?
Sir, may I?
Yes.
Okay, sir. So I think in case 1, what is happening is actually enabling behavior from
Yes.
wife.
Very good. Yes.
Yes, sir. So she is actually providing money, and in a way, just to avoid any arguments and conflict and domestic violence,
Yes.
she is actually reinforcing husband's behavior of substance use.
Yes, yes, exactly. So in case one, it appears that patient is in a pre-contemplation stage, that he doesn't feel that there is any requirement for treatment. This is a classic case in which the patient doesn't show up with the wife in OPD, and the parents or the wife calls you that मेरे हस्बैंड बहुत ज्यादा पीते हैं, मुझे उसको रिहैब में डालना है, या उनका कुछ दवाई गोली मिल सकता है क्या, कुछ हो सकता है क्या. So this is the case of pre-contemplation, or you can see all these enabling behaviors, like, because the most common reason also in the studies it has been found that because of the fear of this domestic violence, money is given by wife for substance use. See, the family dynamics has also changed. Wife earlier who used to not work, now she has to work to earn some money so that she can take care of the family. That there is lot of society pressures and parental fears which makes her not dissolve the marriage also. She has gone to her family members, but they are not ready to keep her. And also she is not ready to stay with them because she fears that how will she raise the child alone? Because most of the time the female is not the chief earning member in the family. So all these things are a kind of enabling behavior, which is because of either because of fear, because of stigma, because of shame, and because of our cultural pressures that one is able to maintain. During intoxication also, see, this is also a behavior that most of the time when the person falls, they try to put him on the bed and they cover him up for the next day for the job, that आज वो नहीं आएगा काम पे क्योंकि कुछ काम आ गया, ऐसा गया, but they are not able to tell that because of his drinking he is not going to job. And all these things are a kind of enabling behavior, and the wife is a codependent in this case, who has put herself completely behind this person so that his drinking can be stopped. Gradually, she has developed these psychological issues like anxiety, sadness, and finally, she is looking for something that can make his husband recover, either some medications or either some kind of rehab. This case, the case two, is a patient who is completely motivated to visit. Okay, he is a motivated patient. He has good insights about his alcohol use. He is in a preparation phase, you can say, and he has tried to visit psychiatrist and he has stopped. He's taking the treatment. But now, what I wanted to make through this case is that everyone cannot be at the same point in reducing alcohol. There can be people who, at some point of trying time, are not ready to completely stop. Okay, and they want something like harm reduction strategies that they will gradually decrease. So, but when you explain all these harm reduction strategies, the family member, the wife, they are not satisfied because they don't feel that that is kind of a treatment. So even the small efforts that the husband is making, who was drinking daily heavily, who has stopped, and he has now drinking occasionally, she doesn't feel that he's taking an effort, and she doesn't have any uh, education regarding substance use, the disease model of substance use, and the other things, that why he is not able to stop. There is no communication between husband and wife regarding how this 2 to 3 days can be stopped. She doesn't ask him that why are you drinking, what help I can do. He doesn't tell him that why he is drinking, because the communication pattern is such that when he comes home drinking, there is an argument, heated argument, and he is not able to reveal that to the wife. So this is a second scenario that happens in home. So here you can see that what has happened because of this guilt and shame, they, because he has not stopped completely drinking, this is also very common, that they keep a watch on him and they tell that you don't have to go alone. Many a times, husband stops going to work and he sits home idly, which is again a risk factor for relapse, that he is not doing anything. He is going to his work with with his father, and in 24 hour he is under scrutiny and supervision. That is bringing a lot of guilt and shame inside him. So this is different from the first case because this person is motivated. Now every person is different. You cannot do same thing to every person. If you'd have done this to a patient who is in pre-contemplation stage, okay, for initial phase it is fine. But this patient who has come to treatment by self, you are doing this to him and not trying to understand. So this becomes a different case. So because of all this guilt and shame, and a wife having no trust in him, he is caught in guilt, the in circle of guilt and shame. And because of this constant criticism and no praising of his efforts, he again drinks. And this is actually a real case which I have seen, that he told me कि जब भी मेरे साथ किसी ना किसी दिन कोई कारण से मेरे पापा नहीं रहते हैं गाड़ी में, और जब भी मुझे ऐसा टाइम मिलता है जब मैं गाड़ी में अकेले रहता हूँ, तो मुझे इतनी तेज तलब लगती है, इतनी तेज अर्ज होती है, मैं उस समय पी लेता हूँ. ठीक है. एंड द रेस्ट ऑफ डेज व्हेन ही इज विद पीपल, ही इज नॉट ड्रिंकिंग. नाउ दिस थर्ड केस, this is a case of a contemplator who is in ambivalence. जब आप किसी contemplator के साथ रहोगे ना, तो he will mostly वो ना he will be ready to take medications. The wife will come, they will tell that that patient is ready to take medications, and but he doesn't have time to visit because he is still in that ambivalence, that whether the alcohol use is that a significant problem to him. And many a times he is in if you see the severity of his addiction, he is not very it may, if you rate it from 0 to 10, it will be around 4 to 5. Because of that, he is not thinking that that alcohol use or the substance use is causing a problem, because he's doing good in finances. These are the people who are drinking in the evening, 1 pack, 2 pack. But the family member, the wife, is worried because they start facing medical consequences like blackouts and passing away. And you can see that wife is constantly nagging that you go to the psychiatrist. He is not ready, but he has started taking medications. When he has started taking medications, he is not reporting to the wife or telling that whether he is fine with medications, whether he needs to increase. This shows that how reluctant he is to take, or how reluctant he is to go into the treatment. He's just taking these medications so that the wife is happy that he is taking some medications. And gradually this brings frustration and stigma. Many a times what happens in these higher socioeconomic status families, because of lot of alcohol going away in the family and the stress, female also starts drinking. And this is also a real case study in which wife has started actually drinking because of the sleep issues at night. So now coming to the slide. So these are the common burden. The burden study in India was also done, and these are the common burdens which everyone knows that is faced by women of substance using disorder. The stigma of substance use, the intimate partner violence, financial difficulties, emotional difficulties, disruptions in family interactions, enabling, which we have discussed earlier, mental health issues, neglect of children, compromised dignity, and also health risks like HIV and other uh, viral illnesses. So every day, every 2 to 3 days, or multiple times, you will see in newspaper these kind of things, that because the increase in domestic violence, and according to cops, you can see the alcohol addiction is the main reason for domestic violence. In this case, you see the Ludhiana has witnessed the worst of crimes involving who took to drugs. So drugs and alcohol, they are one of the main reason that is responsible for shattering of the family as a whole. Either it is the wife, either it is the patient himself, or either it is the children's. One thing which I would like to tell over here is there is one difference between alcohol and other illicit drugs. Alcohol is the major substance that is involved in domestic violence. Okay. The other substances, they have different problems, but the domestic violence uh, with other illicit drugs is less as compared to alcohol. So this is the cycle that goes on, that the person is using substance, he is denying that I am not using much, मेरे को कोई problem नहीं है, because of his cognitive distortions. फिर because of all his substances family में problems हो रहे हैं, wife constantly fighting, constantly family distress, and this vicious cycle goes on. So this is the pattern, especially in our Indian society, that continues substance use, and that is happening in the family. So what do we see? We see that substance use is a family disease because patient does not exist in isolation, and as substance use starts in the family, others also try to change their behavior to bring the family to a homeostasis or stability. We are trying to control someone who does not want to be controlled, and because of all this the addicted person becomes defensive and withdrawn, and there are some family interactions that reinforce the person into substance use, and the vicious cycle goes on. So as we saw, spouses are the chief enablers. What does enabling mean is that knowingly or unknowingly we do things that allow addiction to progress. For example, in the earlier cases, we saw that lying or making excuses for addicted person's symptoms, calling employer to say that person is sick. And the main cause is fear, safety, cultural stigma, shame, guilt, taking the blame of other persons, no discussion of drug use due to fear of violence, providing money for substance use, simply threatening to leave the user but never leaving, drinking or using drugs in hope of improving relationships. And these enablers are called as codependent. Enabling is a kind of behavior, and the person doing this behavior is called as codependent. And codependents are those who define their self-worth or goodness based on someone else. Now the life is completely focused around the husband. Husband's life is focused around the substance, the wife's life is focused around the husband. So codependence is also a type of addiction. They choose a relationship in which another person needs to be rescued. They believe that other are incapable of taking care of themselves. These are also cognitive distortions that the codependent person develops inside him, that I am the only one who can help him, and even if the other person is not ready for help, I have got this responsibility that I will do something for him, I will do one or the other thing to help him. And they always react in an oversensitive manner, and they are very hyper vigilant. Now when the person comes home, they'll see that whether he's walking normally or not, they'll try to smell his mouth, they'll multiple times they will check him, trying that आज तो तुम पी के आए हो, whether they are very sure or not कि उसने पिया है कि नहीं. So all these kind of behavior starts, and they compromise their own values, they compromise their own mental health to avoid this rejection. So Indian women, what happens in an Indian family is कि पेशेंट ने अल्कोहल ड्रग चालू कर दिया है, तो अब इसको हमें बाहर की दुनिया से प्रोटेक्ट करना है, इससे सारी रिस्पॉन्सिबिलिटीज ले लो, इसको कहीं बाहर मत जाने दो, डोंट अलाउ हिम टू गो एनीवेयर, इंटेंस स्क्रूटिनी रखो इसके ऊपर, दिन सर्च इज स्मेल इज माउथ, सर्च इज क्लोथ, रेगुलर क्वेश्चनिंग कि सब्सटेंस यूज लिया है कि नहीं, मेंटेन ए बिहेवियर ऑफ ब्लेम, तुमने कल ये पिया था, आज कल ऐसा किया, कल ऐसा किया, तुमने पी के पूरे फैमिली का नाम खराब कर दिया है. पास्ट इश्यूज को बार बार लाना, इवन व्हेन ही हैज मेंटेन्ड सोबरिटी फॉर अ डे और अ टू, they are not happy. Wife starts job and husband is sitting at home. This is a major family shift that happens. And then there is a lot of guilt, shame, criticism, and boredom. This is the way that we deal a substance user in a family. And because of all this dealing, these problems they face of intimate partner violence, of shame, of guilt, and others which we have discussed. Now coming to the main issue कि how to bring this substance user to treatment. उनका एक ही चीज रहता है कि इनको ठीक करो, ये इलाज के लिए नहीं आना चाहते, इनको इनका इलाज कैसे किया जाए, या even if he wants to come, stop his alcohol use completely. Now what I will do is this is the literature that is available, that how to bring substance user to treatment. Okay, earlier there were approaches like Al-Anon and Johnson intervention. Now Al-Anon is a concept of loving detachment. उसमें Al-Anon, when you attend an Al-Anon meeting, they will tell you that कि substance use is his responsibility, आपका वो responsibility नहीं है. आप अपने mental health को या you अपने हेल्थ को उसके पीछे कंप्लीटली डिस्ट्रॉय मत करो. You detach from him, you start having your own life, you start living your own life. Okay, but this is not but this doesn't bring patient to treatment. In Johnson intervention, what happens is it is a kind of confrontational approach, that someday many बहुत सारे relatives patient के पास आ जाते हैं, and they tell patient that because of your alcohol use or the substance use, all these problems are happening. And they give a party and they tell him that we will give you these 1 2 3 4 5 options, and now you have to choose one option now only, and from that we will act tomorrow. Either you have to go a rehab or you have to go to a doctor. But this has also been not very helpful. So what two things that has been found to be helpful is, one is this craft approach and one is this behavioral couples therapy. So I will discuss this, and some of I don't think that all of this can be applied in our setting, in our OPD, in our culture, but we can extract some things from this and use an eclectic approach in managing patients. Now this community reinforcement approach, it it has two parts. One is for patients and one is for, I defined, one is for the concerned significant other. They call it a CSO, concerned significant other, who is generally a spouse. Generally it is a wife or mother. So we will omit the patient's part and we will generally only discuss the part of wife and mother. So it works on the principle that in the family there are positive reinforcers and contingencies, which if applied properly, that can move the client to a substance free behavior. And it also works on the psychological health of the spouse, the mother or the wife. And it asks whether the client enters the treatment or not. You have to look beyond the substance use. You have to look at the family's health also. You have to look at yours health also first, and then only we can help the substance user to get into the treatment. सो इट आस्क्स कि ठीक है, अगर पेशेंट नहीं आ रहा है तो आप पहले आओ और आप सेशंस लो. ठीक है, इट इज़ अ मैनुअलाइज्ड अप्रोच. पूरा इसका एक मैनुअल है जिसमें कैसे सेशंस लेना है, पहले सेशन में क्या करना है, दूसरे सेशन में क्या करना है. आई हैव टेकन अ ग्लिम्स ऑफ इट एंड आई विल डिस्कस ओनली कि आप वन उसमें फर्स्ट पार्ट इज दैट फंक्शनल एनालिसिस ऑफ सब्सटेंस यूज ऑफ द पेशेंट. कि पहले सेशन में आप वाइफ या जो भी स्पाउस है उससे पूछो कि वो क्या लेता है, ताकि यू गेट टू नो what information she has of his substance use, how much he drink, on what days he drink, is there any violence under intoxication, what the blackouts, whether he's going to job or not, what legal complications he's facing, whether he's having many medical issues or not. And then on basis of that, everything is planned. The treatment is planned and everything is planned through changing the pattern of communication skills through role plays. Now the role play is done between the therapist and between the wife or spouse in the clinic or in the session room, that this is the way or these are the words that you have to tell by identifying the family patterns. So the first part is learning to communicate positively. So for example, one of the example is this. The first part is understanding statement, that how you have to change the same thing and tell it in a different way. For example, if someone comes at home from work after drinking, generally the wife says, "आप पी के आए हो ना, आज आप पी के आए हो," and then the fight and the heated argument starts. So you have to tell like, drinking after work to relieve stress or enjoy before coming home. So this statement and the statement of the other in a tone of aggression or criticism, that you have drunk today also, every day you are drinking, you don't care about family. There is a difference. So this is the first part that you have to do. The second part is that you have to take partial responsibility. So what you have to do is that you have to tell, for example, like that, this, because of your drinking habit, we are not able to spend time together. Your health is deteriorating and you are not able to go on work next day. So you have to bring whatever is the most concerning part that you have realized because of his substance use, that what is the most important thing that is uh, happening, and you have to bring that part. And then you have to offer him help, that uh, can you tell me that how can I help you? And even if you have few suggestions you can give, you have to decide when to approach for all of this. When a person is intoxicated, that is not a time to do all this. When he's not under intoxication, gradually you can do all this. And even you have to be prepared that he will react negatively for the first time, for the second time, and then you have to again go to the therapist and discuss. You have to show concern instead of nagging, and you have to use a positive tone. Now you have to use some kind of positive reinforcement that this therapy believes that runs in the family. For example, if someone is very interested in watching television, so the wife tells that if you are sober, we can watch television together. So she will tell that I love spending time with you when you are sober. And it can, and even for his small effort of being sober, you praise him, you give him a hug, and you tell him that at least you have tried for today. We can do it, we can stop the substance. That kind of talking is empowering instead of enabling. So the next thing is also a timeout, that you have to stop the enabling behaviors. For example, if it is a pre-decided that the wife will tell to husband that if you come at home after drink and you do not go to your work, next day I'll not cover up for you. So, so this is an example, like today I'll not go out with you as you have drunk today, and we have to deal with this only if you are sober. So today we had planned a movie, but because you are drunk, I'll not go out with you. So we can try it again tomorrow when you are sober. Then also allow natural consequences of substance use to occur, uh, keeping in mind the safety of the patient. For example, don't call at work and give excuses for his next day hangover at workplace or cover up for him. The third part deals with improving the life of the wife or spouse, because she feels that she has been isolated and she is the only member who is taking care of the family. You ask her to involve in recreational activity, social support, connect with friend, manage social isolation. And uh, and uh, this this therapy also has a happiness index scale, which is very nice, in which you ask the patient. You can apply it in patient also, or you can apply it in the on the spouse also. जैसे फॉर एग्जांपल यू हैव टू टेल कि 0 to 10 में आप बताओ कि आप अपने अगर आप पेशेंट से पूछ रहे हो तो कि 0 to 10 में आप बताओ कि आपने जो ड्रिंकिंग कम किया है उसमें और हम लोग क्या कर सकते हैं, या कितना आपको लगता है कि अच्छा है. इफ द पेशेंट टेल्स कि ओके 7, तो आप उसको बोलो कि वाई नॉट 6 एंड वाई नॉट 8. तो देन ही विल बी एबल टू थिंक ओवर इट एंड ही विल बी एबल टू गिव एन आंसर. फॉर एग्जाम्पल, क्रेविंग के लिए आप उससे पूछो कि 0 to 10 में आप बताओ कि आपको लगता है कि आपको क्रेविंग किस टाइम होती है या क्या. he'll tell you okay पूरे दिन में मुझे क्रेविंग 6 जैसा है. तो ही उसको सब्जेक्टिवली करने के लिए यू टेल हिम व्हाई नॉट 7, what made you think of 6. So all these will give you some good and better answers. Final stage is asking patient for treatment. You have to look for windows of opportunity. बहुत बार जब फीमेल सेशन कर रही होती है, दिस इज समथिंग दैट इज गोइंग ऑन इन द वेस्ट. तो जो मेल मेंबर होता है वो पूछता है कि यू आर गोइंग टू सेशंस, व्हाई आर यू गोइंग टू सेशंस. तो शी विल टेल दैट I want to improve my relationship with you in the family. I'm not because you are drinking, but still I want to have a good relationship with you, so I am going to sessions. And then she can tell that why don't you come and try 1 or 2 sessions with me, it has helped me improve our relationship. Also, many a time husband will notice that her way of communication with him has changed, and he can tell that you have started talking to me in a very good tone or in a different style. And she can tell that it has all happened because of sessions, and she can ask him to visit the doctor without uh, uh, making any commitment of next visit or long term visits. So this will help him bring the patient to the doctor. Now, the other thing is BCT, this behavioral couple therapy. This can be applied in patients who are in contemplation or preparation phase. So I'll go in little fast that it talks about a recovery contract, that is also called as trust discussion, and it has it stays on his intent that you have to work one day at a time. That is an A principle. Every day the spouse has to express support and thank patient for effort he is taking. And if the medication is on, the medication should be supervised daily, verbally. The patient is ingesting and witnessed. And all this is not discussed just with one person, this is discussed with both. And the husband and wife both are comfortable for this contact. They have to focus on present and future. Don't have to bring about past. There is no talk about कि past में आपने ऐसा किया था वैसा किया था. Weekly urine drug screens can also be added. Going to self-help groups can also be added. It talks about involving in some mutually enjoyable activity. Even if the person is drinking, you can start with these activities. It is not that if the person has stopped drinking, then only you will do all these activities. For example, you can keep surprise activities for each other irrespective of sobriety. If there are any heated arguments, there one can start time out कि अभी हम लोग बात नहीं करेंगे, I'll go out and we can discuss later in a calmer way. So this is an example of how this recovery contract is made. In the first part, you can see that this is the form they fill, in which patient's responsibilities and partner's responsibilities are given. In daily trust discussion is talked, in which the patient states his intention to stay substance free that day, and the partner thanks or supports him in his recovery. There is no talk on future, no talk on past, and only the focus is on present and future. If self-help groups are involved, weekly self-help meetings are talked about, urine drug screens are talked about. Okay, and then every time you visit back to the therapist, this calendar has to be brought. Because when patient and the wife comes, so when you ask them कि आपने पिछले महीने में कितनी बार पिया या क्या हुआ, तो पेशेंट विल टेल मैंने 2 बार पिया, शी विल टेल कि नहीं नहीं 2 बार नहीं 4 बार पिया था, एक दिन ये था. And again all these things will happen. And it has been found that verbal discussion and doing this actually in a calendar, there is a lot of difference that brings. So every day you have to mark. In this you can see D is written for disulfiram, that on, and T is for the day he has been sober, कि उसने मेडिसिन लिया, सोबर था, एक दिन मेडिसिन नहीं लिया. So when it comes to the therapist, he can evaluate all this properly, and he can tell that how what has happened actually in the month. And this can be prepared by wife also and by husband also. दोनों अपना अलग अलग भी बना सकते हैं. Okay. So what needs to be done is that we need to work with family members to promote the entry of substance user. Joint involvement of family members and substance using relatives, interventions for family members, and we have to provide them self-help manuals. Now, what barriers? All this is going in West, but most of it is not possible in our settings. So this was a study that was done based on all these only Kraft and this BCT. They have developed a 5C strategy. It all almost tells the same thing, and it was not very successful on some terms. And what they found was कि family members ने बोला कि they are not interested in sessions, क्योंकि हमारा एक ही प्रॉब्लम है कि ही इज ड्रिंकिंग, उसका ड्रिंकिंग बंद हो जाएगा तो हमारा फिजिकल हेल्थ, मेंटल हेल्थ सब ठीक हो जाएगा. They don't see the usefulness of intervention for themselves. They want the substance using population to engage in the treatment. And the other issues, one of the major issues is cost, logistics, how to apply, sessions कैसे लें, fees, and also the other thing is कि they all want a quick fix. इंडिया में हेल्प में क्या प्रॉब्लम्स आ रहे हैं कि स्टिग्मा एंड शेम डिस्करेजेस हेल्प सीकिंग. There is also problem in locating formal and informal help seeking services. They don't know whether it is treatable, where to go to a doctor, go to a baba, directly go to a rehab, get admitted. There are previous negative experiences also with help seeking. There are financial constraints. There is all this has led to hopelessness. And when they come to you, they tell कि हमने सब चीज ट्राई कर लिया है, अब हमसे कुछ नहीं होगा, अब ये नहीं छोड़ रहा है, क्या करें. So this is one example of what can happen if all this can be used and approached. We take the same example now that Mr. X and his wife both agreed for a session. If a patient is in at least a contemplation stage, wife was educated, आपने उसको educate किया about substance use, that how it is a disease. You educate him about slips, दैट अभी छोड़ दिया इसका मतलब पूरा बंद रहेगा 6 महीना, ऐसा मेरी कोई गारंटी नहीं है. स्लिप्स आर अ पार्ट ऑफ सब्सटेंस यूज डिसऑर्डर, एंड एवरी स्लिप इज एन अपॉर्चुनिटी टू लर्न एंड रिकॉग्नाइज द ट्रिगर्स इंस्टेड ऑफ शेम एंड गिल्ट. जैसे ही वो स्लिप करता है, शी स्टार्ट्स टेलिंग, द वाइफ टेल्स की अब तुमको छोड़ना ही नहीं है, तुमसे छूटेगा ही नहीं. हस्बैंड गिल्ट में आ जाता है कि यार सही में ये मेरे से छूटने का बात नहीं है. एंड देन देर इज ए समथिंग कॉल्ड एज एब्स्टिनेंस वायलेशन इफेक्ट, कि whenever the husband breaks the abstinence, he himself starts feeling guilty and he thinks that मेरे से नहीं होने वाला, and he starts drinking again. Husband discussed his substance use with wife regarding his alcohol. Husband को discuss करना पड़ेगा कि वो क्या पीता है, कैसे पीता है, क्या उसके patterns हैं, किस टाइम पे उसको दिक्कत होती है. For example, in this he recognized that evening time and coming from workplace was a craving trigger and he could not resist. He dissolved his shame and guilt. He got ready to call his wife after work, that he will not come home alone from that same place alone, because that triggers his craving. And instead of that, they will go to a coffee shop. Wife starts praising every small efforts of him not trying to drink. Husband has started taking medications in front of his wife based on a supervised regimen. And बिकॉज ही हैज कम टू नो दैट कि मुझे जब बहुत क्रेविंग होगी तो मैं मेडिसिन खुद से नहीं लूंगा. दैट हैज बीन टॉट टू हिम, सो दैट मेडिकेशन सुपरविजन इज वेरी एसेंशियल. क्योंकि आप जब पेशेंट को बोलोगे तो वो बोलेगा कि आपको मेरे पर विश्वास नहीं है कि मैं नहीं लूंगा, वो क्यों मेरे को दवाई देगी, मैं खुद ही खा लूंगा ना. सो यू नीड टू एक्सप्लेन व्हाई यू वांट दिस सुपरविजन. whenever there are slips, it was told कि क्योंकि because there is loss of control in many patients, नेक्स्ट डे से आप फिर वही पैटर्न पे नहीं आ जाओ, आप अगले दिन डॉक्टर के पास आओ ताकि कुछ चेंजेस, कुछ सजेशंस हो पाए. आप धीरे धीरे अपने लैप्सेस के ट्रिगर्स को आइडेंटिफाई करो. जब आप इंटॉक्सिकेटेड हो तो यू स्टॉप ऑल डिस्कशन एंड just look for the safety of the patient and try to make the patient sleep so that you can talk next day. वाइफ के साथ एंगर कंट्रोल डिस्कस करना बहुत जरूरी है, क्योंकि हमारा भी वो इंडियन फैमिलीज का वो कंडीशनिंग हुआ है कि ये सब बोलना बहुत आसान है, बट एक्चुअली डूइंग इट इज वेरी हार्ड. वो भी लैप्स और रिलैप्स कर जाते हैं. जैसे ही उसको दिखता है कि हस्बैंड पी के आया है, वो वही मोड में चले जाते हैं, तुम फिर पी के आ गए. ये तो सी ऑल्सो हैज टू कीप इन माइंड एंड रिहर्स कंटिन्यूअसली दैट what I have been taught and how I have to react in front of his drinking, and then gradually things can change. So mutual trust, as the mutual trust develops between the husband and the wife, the substance use becomes open. चूहा बिल्ली का जो खेल चल रहा होता है वो खत्म हो जाता है, and now they know about everything, each another, and they can help each other in better ways. So what way forward? There are self-help groups that have been formed in India. एक दो हेल्प ग्रुप, एक बैंगलोर पुलिस का हेल्प ग्रुप है, वनीता शाह आवानी करके, जो डोमेस्टिक वायलेंस से विमेन को बचाते हैं when they are intoxicated. They arrange counseling. They also bring patient to substance use treatment. There are also self-help groups that are running in Imphal and Pune. So all these things have started, but there is still way forward. Thank you.
Thank you, sir, for the very insightful lecture, I would say, because we all know that this topic is very relevant in this time. But of course, we come across this kind of
Now the
dilemma.
session is open for any questions.
Yes, sir. So actually, nowadays we come across this kind of dilemma when family members come with their baggage.
Dr. Alapi, can you hear me?
Yes, sir. Yes, sir. I am able to hear you. Yes, sir. Am I audible, sir?
Yes, yes, you
Hello.
are audible. You continue.
Yes. Okay, okay, sir. So thank you, sir, for this insightful lecture.
Voice is not, I'm not able to hear. Okay. Okay, yes.
Yes.
Yes, you
Thank
are
you,
also
sir.
audible.
Piyush sir, are you able to hear me?
Yeah.
Okay, okay, sir. Thank you, sir, for
सेशंस चल रहा था ना, मुझे लग रहा है कहीं मैं अकेले ही तो नहीं बोल रहा था.
नहीं, sir. It was clear. Yes.
Okay.
Okay, sir. Thank you, sir, for this very interesting lecture, I would say, because you shared very important clinical tips for all of us. Because many a times we come across this kind of situation where family members come with their baggage and then the person is still abusing substance, we are treating. Also, we are having some counter transference. So, of course, it is a very difficult situation. So, it was very practical and very insightful. Thank you, sir. If anybody has any question, you can put in the chat box, or you can even ask to sir.
Dr. Piyush, great.
Can I ask a question, Dr. Piyush?
Yes, sir. Hello, sir. How are you?
Very well. Topic covered very well, and it's good, insightful. Thank you for this good understanding about how the wife or spouse can help the person. Because in India, mostly it is a blame game.
Yes,
that is
sir.
a chuha billi khel. So that's a very wonderful things you have explained, that how the spouse can really support. Yes. Okay. Yes.
Thank you, sir.
Well done, Piyush. Dr. Bhavesh.
Thank you, sir. Yes, sir. Thank you.
It is very routinely done in our routine practice. We have to teach our residents how to deal with the patients of alcohol dependence and their family members.
Yeah.
Because they don't know. Initially, they start confronting.
Yes,
the patient
I
and
think
their
we
family
can.
members.
Yes, sir. I think we can bring some of the point. अगर हम लोग, even if we are not able to do all the things, we can bring some of the points and we can help. I have started doing some things in my patients. For example, if the patient comes with wife, some components of behavioral therapy, couple therapy can be used. They can be taught about these slips and relapse. All these things can be done. Maybe call them every 10 days, call them multiple times. You decide. So there are lot of hurdles, but still things can change, I think.
Yes, yes. And in dry state, we see many such patients. In our
Yes, yes.
wards, around 75% of the admissions are of alcohol dependence.
Yeah, alcohol dependence is the most common. Yes.
Sir, there is another question from in the chat box from Dr. Achal. He asked that, sir, can you please guide on how to counsel the wife of alcoholic person who is struggling with physical abuse from her husband and not able to stop him?
Again, we need to discuss with her that this physical abuse is not acceptable. Now, the context of physical abuse, uh, one should be able to know that whether it is just under alcohol intoxication, or whether it is due to substance abuse, or whether it is a general part of the personality. Many times, if you look beyond the substance use of the patient, actually the history doesn't tell that the personality is secondary. The personality is the primary part, that the person has antisocial personality traits, and the alcohol use has just exaggerated it. So you need to know whether that abuse has been just due to substance use, whether that abuse was previously also when he was not consuming substance. And she first most of them are the victims. They don't discuss all this abuse with any of the family members or any of the they don't go to any of the legal authority also. Just as we discussed, that it becomes a kind of enabling behavior कि उनको पता चल जाएगा तो फिर मेरे हस्बैंड के ऊपर इतने सारे प्रॉब्लम्स आएंगे, and that keeps on going. So at one point of time, she needs to take a strict action. She need to stop that. If that this abuse is taking place, she needs to go to her family members. She needs to go to the local authority also. अब इन सूरत लोकल अथॉरिटी में भी जाने में प्रॉब्लम है बिकॉज ऑफ दिस ड्राई स्टेट थिंग. बहुत सारे पेशेंट्स आते हैं मेरे पास रिहैब से. वो पेशेंट बताता है कि हमको वहाँ पे बहुत मारा, ये किया. दे टॉक टू देयर फैमिली मेंबर ऑल्सो. फैमिली मेंबर भी बहुत गुस्सा होते हैं. बट द थिंग इज दैट दे आर नॉट एबल टू गो टू द अथॉरिटी, क्योंकि सबसे पहले दे फील कि हम लोग जाएंगे वहाँ बोलेंगे कि ये अल्कोहल पीता है, द थिंग्स विल चेंज देयर ओनली. कि they will tell how उसी को पकड़ लेंगे कि ये अल्कोहल पीता था. So all these problems make her or him to suffer silently.
Yes, sir. Sir, I also wanted to share one recent case I came across, and I would like to have your guidance on that. Actually, he's a patient of us, and he was on alcohol dependence, and we admitted him. He was started on medicines. Currently, he is on disulfiram and even anti-craving agents. And he is out of now alcohol. He is recovering, and he has maintained this abstinence from alcohol. And he just came in the routine follow up, and he expressed his depressive symptoms, telling that family members are not letting him go and work, which he used to do previously. And he was high functioning, he was working well and even earning well. But now, as family members are afraid that he might go out and again start abusing alcohol, and that's why they are stopping him. And that is the reason that even he went for even attempting suicide out of depression. So what can be done here, and how can we manage keep the balance between keeping him abstinent and also for him to go and work?
This is the third case which I discussed. Okay. Now you have to decide कि patient is a contemplator or he is highly motivated. So अगर मान लो patient is in a pre-contemplator, then you can this is what I do. You can tell फैमिली मेंबर कि ठीक है अभी 15-20 दिन तो इसको नहीं बाहर जाने देना है और आपको इसको साथ में रहना है, बट यू हैव टू टेल हिम इन फ्रंट ऑफ द पेशेंट. या पेशेंट को भी उसको समझाओ कि देखो अभी तुम जाओगे तो तुम्हारा वापस से अल्कोहल यूज करने का चांस ज्यादा है. उस बीच तुम वो पीयर ग्रुप से हटो, यू स्टार्ट ऑल्टरनेट एक्टिविटीज, आप मेडिकेशन लो, ठीक है. बट ग्रेजुअली इफ ही इज एबल टू डू ऑल दिस, ग्रेजुअली फैमिली मेंबर का ये फियर है कि वो बाहर जाएगा तो पिएगा. नाउ यू हैव टू मेक हिम अवेयर कि अगर पी लेगा तो पी लेगा, इसमें क्या बहुत बड़ी बात है, ऐसे भी इतने पहले से पी रहा था ना, एक दिन पी लेगा उसके बाद वी कैन डू समथिंग. हम लोग को पता तो चलेगा कि वो पिया, क्यों पिया, कैसे पिया, कितने दिन तक आप उसको घर में एडमिट करके रखोगे. नाउ दिस इज द प्रॉब्लम विथ रिहैब ऑल्सो. ओके, बहुत पेशेंट 6 महीने रिहैब रहते हैं, निकलते गेट के बाहर ही पी लेते हैं. ठीक है, कि मेरे को 6 महीने से मैं वेट कर रहा था कि मेरे को कब ये लोग छोड़े हैं और मैं जाके पीऊं. ठीक है. और द साइंस टेल्स दैट दिस कम्युनिटी रीइंफोर्समेंट अप्रोच एंड ऑल दिस, ये सब इस साइंटिफिक नोशन पे बना हुआ है कि जिस कम्युनिटी में आप रहते हो, द कम्युनिटी इन विच यू रिसाइड, जिस कम्युनिटी में आपने ये सब्सटेंस यूज शुरू किया है, जैसे आपने शुरू किया आपका कोपिंग स्ट्रेटेजी, आपका वे ऑफ लिविंग इन द कम्युनिटी चेंज्ड, उसी सेम कम्युनिटी में आपको उसको बंद भी करना है. ओके, यू हैव टू इट्स लाइक जैसे एक्सपोजर रिस्पॉन्स हम करते हैं ओसीडी के लिए ना, कि आपको एक्सपोज होना है उन चीज़ों से और वापस से न्यू कोपिंग स्ट्रेटजीज और न्यू स्किल्स डेवलप करना है और उन सबको फेस करके वापस से वही सेम कम्युनिटी में आपको बंद करना है. दैट इज वाई मेनी टाइम्स रिहैब्स आर नॉट वेरी सक्सेसफुल, क्योंकि वहाँ पे कुछ रिहैब्स में तो होटल जैसा है, आप रिहैब्स में जाते हो, सोते हो आराम से, खाते हो पीते हो, स्विमिंग पूल में एंजॉय करते हो, पर जैसे ही 2 महीने बाद बाहर आते हो, वही फ्रेंड्स, वही इन्वायरमेंट, वही स्ट्रेस, और अगले दिन पीना चालू, बिकॉज यू हैवंट लर्नड एनीथिंग. Okay, so doing it in the same community, doing it with the same group of people, handling it, so this CRA teaches you this role play. हम लोग भी वो कंडीशन नहीं, जैसे ही सब्सटेंस, अभी उसकी वाइफ, एक पेशेंट उसकी वाइफ ने कल ही आए थे, उसने बोला कि सर आपने इतना सिखाया तो था मुझे, पर वो कल पी के आया, मेरे से कंट्रोल नहीं हुआ, मैंने बोल दिया तुम्हारा क्या, तुम कभी नहीं सुधरोगे, तुम्हारे कारण घर चौपट हो गया है, ये वो. फिर उसने फिर रियलाइज किया, अरे आई एम गोइंग टू द सेम मोड. सो उसको खुद भी अब बार बार वो प्रिपेयर हमें करना पड़ेगा कि हमें उससे कैसे बात करना है. So it is a tough task actually, but I think if it is working in West, why can't it work here? खाली द डिफरेंस इज कि द पेशेंट वहाँ पे थोड़े मोटिवेटेड रहते हैं, दे हैव दिस ऑटोनॉमी, they come by self and they ask you that I want, doctor, I want to stop my alcohol use, I want to reduce my alcohol use, what options do you have? हमारे पास ये नहीं है because of this shame and guilt and stigma. बहुत सारे कुछ पेशेंट्स ऐसे भी हैं जिनका ड्रिंकिंग डिपेंडेंस नहीं, कुछ भी नहीं है, उन्होंने 2-3 महीने में 2-4 बार पिया है, बट द पेशेंट्स रिलेटिव वांट हिम टू एडमिट कि इसको सर इसकी 1-2 महीने बाद शादी है, इसने 4 बार पिया है, हमारे कल्चर में एक्सेप्टेबल नहीं है, इसको बंद करना है. सो वी नीड टू ओवरकम ऑल दीज थिंग्स.
Respected Dr. Shirod Mishra has posted that negative comments is one of the important factor for the labs.
Yes, that is very true.
Any other question from the audience? So I think there are no more questions, sir. So
Abhay,
Piyush,
you
do
can
you
come to
do
me
you
and-
practice?
Hmm.
Piyush, do you practice with the patients other than addiction?
Yes, sir. I am doing both kind of practice.
Okay.
sir has also appreciated the talk. Thank you, sir.
Thank you. Thank you, Dr. Alapi, for moderating this session.
Thank
And
you,
thank
sir.
you everyone for being patient.
I think now, as we are concluding the session, I am honored to deliver vote of thanks on behalf of the subcommittee. So first of all, I would like to sincerely thank our esteemed speaker, Dr. Piyush Goyal, sir, for taking his time out to share his experience, clinical wisdom with us. And I think particular mention of that interventional strategies for these substance use patient. Also, the specific models of craft, BCT, they were very interesting. And I think his guidance will definitely help us in our clinical practice. Thank you, sir. I would like to also mention the honorary president, Dr. Shirod Mishra, sir, for being there and encouraging us and always inspiring us. Thank you, sir.
Thank you, Alan. Thank you.
Thank you, sir.
कैसे हो मिश्रा साहब?
Thank you, Vijay. Good night. Good night.
मिश्रा
Yes,
साहब,
nice presentation. We should have
Thank
got
you,
some
sir.
more audience actually. The really good effort by Piyush. Bhavesh bhai, good
मिश्रा
night.
सर, कैसे हो आप?
Thank you.
आप
Good
कैसे
Good
night.
night, sir.
मैं ठीक हूँ.
Also,
Good night.
very warm thanks to our enthusiastic chairperson of Women's Mental Health Subcommittee, Dr. Ritamra Madam, for always being very encouraging and also to encourage all our committee members to be on our toes and organize this kind of meaningful academic feast. I would also like to thank all our subcommittee members for their relentless work behind the scenes. And finally, I would like to thank my audience for being there and attending this session. Thanks to our support team for making this execution very smooth. And with gratitude and hope for continued collaboration, I formally conclude today's webinar. Thank you.
Thank you, nicely moderating. Good night.
Good night. Good night, everyone.
Good night.
Good.
Right.